this is pure speculation, but perhaps if you left it longer, if you had a tamponade which was left in longer or degraded more slowly, that it may be possible. But again, you know, this is an area that's totally unexpected. But theoretically, it is possible. I mean, we know that you can actually lengthen a leg, for example, if you lengthen it slowly. So perhaps you could perhaps it could actually regenerate. But whether this was actually a regeneration, we really don't know. These are just very preliminary findings, and we'll have to repeat it.
Okay, thank you so much. Humberto?
Yeah, so I think it's wonderful work. I think that if we see your talk and going backwards through the other talks, we really see how this is revolutionary in terms of how PFO and oil enabled us as surgeons in the past to really change the outcomes. And if we take into account the possibility of this has been talking about for probably the last 10 years, having this is going to have the same impact as these other two tamponades. And in addition, as you mentioned in the end, this in combination with the upcoming treatments for probably some other diseases, because of the possibility of using it as a media to add some form of medication or even gene treatments, etc. This matrix is the potential is great, and I think it's something definitely we have to look forward to.
Thank you, Carly. Mario, yo creo que por respeto a Caroline y al doctor Regilio, si no te importa, lo vamos a tener que hacer en inglés, si tú estás de acuerdo.
Yes, let's do it in English. But if you don't mind, I would like to ask something to
Claro,
Caroline
adelante.
before.
Go.
Caroline, I'm trying to understand. When you substitute inside, after that, it gets hard. So, did I understand? All right. Is it all right what I'm saying? I mean, the substitute gets harder, or it keeps like fluid.
So it is heat sensitive. So when it's cool, it's in a liquid form, and when it's in the eye and warms up, then it'll turn into a gel, and then over time it's biodegradable. So over time it actually degenerates and it's just basically disappears. So
I'm interested in how it. Oh, I'm sorry.
No, carry on.
Okay.
I'm interested. It works as a tamponade because how it works, for instance, in inferior lesions or.
Well, yes, it can work in inferior lesions as well, because it fills up the whole cavity, just like a vitreous body, basically, and that's the intention. How well it will tamponade inferior lesions, I suppose we'll have to, again, when we get the final formulation, repeat those experiments, animal experiments, and see whether they will tamponade the inferior retina just as well. Theoretically, it should if you get a proper fill, if you get a proper full eye fill with it.
Okay.
Thank you.
Mario, in your paper, these inferior lesions with this, how do you say it, lamp patch? Do you did surgery with some vitreoproliferative lesions in some cases?
No, this is a very small series, so that I think this is a week of the series, but I am No, but I prefer to start with cases without PVR and with only one or two lesions, but small lesions, just because we were like tuning our technique. A very important point was how to get the patch of amniotic membrane inside. And it was well, we find a way, but we rather prefer to use small patches. And well, I really try to use easy cases before go for a further a new series, a larger series.
It's a great work. And how long, or what was how long does it last, the patch inside the eye?
Well, the patch, yeah. Well, this is actually, I start using it to close a macular hole, but I failed. I'm telling you, unpublished data, but I failed, and I tell you why. Because why half of the cases the patch was detached the day after or a few days after the surgery, and the other half they stay attached a long time. And in one of those cases, we in August we accomplished 1 year attached to the retina. So that's why I dropped the case. I dropped the work because for the patients, the macular hole were closed, but they couldn't save it because they see blur until the patch was detached. And but that made me to think that, okay, maybe this is not working for macular hole, but yes, for peripheral lesions. So we started with this series at the beginning of the year, and well, as I show you, one of the cases, like more than 6 months after the surgery, the patch is still attached. But in the others, maybe the patch lasts like 1 month, 2 months, 3 months. But in all cases, time enough to get apexia accomplished.
Thank you so much. Humberto?
Yes, so I think it's wonderful that we're thinking forward, but I would like to ask Dr. Regillo, thinking about these practical, very practical approaches into using this is something that we take for granted. PFO is a tool that most retina surgeons use every day, and as both you and Jordi spoke during your talks, it has potential complications, and I'm very interested in the fact that you choose to perform that complete vitrectomy and then do a complete fill, and the fact is, something that was very clear to me is that when you amputate and enlarge, you're basically doing what, if you don't do it during the surgery, it ends up happening anyway. If you don't shave the hole and amputate the flap, when you do the air fluid exchange, it enlarges anyway, and sometimes you don't have good control over that, and then it enlarges a lot. So I think that's a great point. And I don't know if you want to touch base on the other perils that you mentioned about PFO being such a useful tool when we avoid the potential complications.
Well, thank you. And thank you again for the invitation to be here. It was a great session. I liked the fact that we had my talk, Jordy's talk, looking back on use of perfluoro and silicone that we've had now for decades, and looking forward to some new technologies too. So I'm looking forward to those advances. But it is important, you're right, we have these tools, we have to use them right. And there's ways we can get into trouble, but we can avoid that. I'm glad you brought up the enlarging the break. It's not just enlarging, but it's anterioralizing it too. I will take a break, a typical horseshoe tear in the typical location of the posterior vitreous base, and I extend it virtually all the way to the aura. That helps to ensure that we get all that trapped anterior fluid out when the perfluoro goes up to and over the break. That helps to minimize, of course, anterior fluid tracking back down when you do the perfluorocarbon removal. And over the years, I've not only been more and more generous with opening up the breaks, but anterioralizing the breaks. And it makes the surgery easier, and it helps to ensure that we get as much of that trapped. You can never get 100% of that anterior fluid, that trapped anterior fluid out, but it helps to ensure that we get as much as possible out, because the less we leave under the retina, the less there's a chance for macular ectopia or even folding, which are the types of complications we have to avoid. Those are the types of cases I like perfluoro, in the cases where there's macular involvement, and I want to try to get as much macular fluid out as possible. And I think perfluorocarbon can help us to do that. Although if we don't use it correctly and we do leave trapped anterior fluid that gets displaced posteriorly, later on when we do the perfluoro air exchange, that's when we get into trouble and we can actually create the folds that we're trying to avoid. So it's enlarging the break, like you said, so you don't have to have it tear open and bleed later when you go through the exchange, and also anteriorize it to ensure we get as much subretinal fluid out during the initial fill. And I do fill it all the way up.
And the other question I wanted to reinforce was also that you mentioned that valve cannulas are the standard. In Mexico, it really hasn't happened. For me, it is the case, but it has the repercussion also that what cannula are you using to infuse the PFO, which is, those two things are very important, particularly when we're having a tight pressurized eye constantly.
I'm glad you brought that up. Others will recommend or suggest a dual bore cannula. Med1 makes one, and I've tried it, but it's really kind of slow, although I do advocate putting in the perfluoro slowly. I actually use a standard extrusion needle, and what I do to allow the venting is I still want my valve cannula to be competent, so I don't want to compromise the valve, but I'll take the extrusion needle with the perfluoro in it, and as I inject, I kind of push to the side. That helps the valve to open up, and usually you can get enough venting to occur. Not always, but usually. The time you don't get good venting is when there's not a very complete vitrectomy up and around those, the cannulas themselves. If there's any gel up and around that area, you tend not to get the good venting. But usually you just with a little bit of a sideward movement of the cannula as you inject the perfluoro, you can open up the valve enough or distort it and get some venting and the fluid to come out. Not always. Sometimes I have to come out, put it back in, but you inject it slowly and a little bit of a sideward movement, you can usually accomplish the goal with a single bore cannula.
Thank you so much. Adriana, if you want to go ahead.
Jordy, at the end of your talk, you explained something about the PFO exchange directly with silicone. Do you like to explain it to us?
Sure. So I actually don't use PFO as much, and I'm supporting what Dr. Redonda said. That I sometimes worry that PFO may be sometimes too easy, and some surgeons can just simply throw the PFO in there and may completely miss the presence of this anterior peripheral subretinal fluid if it gets trapped, and it's very difficult to see, but it's there. Dr. Regil uses a technique of anteriorizing the tear, which basically makes, as the PFO goes up, it basically makes the retinal tear be as close to the aura as possible so that the fluid would go out that way, which is absolutely logical and works perfectly well. If you don't do that, remember that what you have to do is when you're doing the PFO removal, and this is something I was saying, so as the fluid PFO goes down, I usually do, and this is going back to your point, I do a PFO air exchange as my preference whenever I can. So as I fill the PFO to wherever I want to fill it, then I'll switch to air, okay? So then rather than do a drainage from the optic nerve site, which the problem that you would have is you would drain all the PFO and then right above it will come the subretinal fluid and BSS and what you may have remnant, is to try to stay to the most that you can above the PFO meniscus so that you remove the BSS overlying the meniscus. And as you come down, when you find the most posterior tear, and this is to the point of Dr. Virgilio, is that there may be subretinal fluid that you're not seeing. So rather than go complete removal of PFO, stay there for a little while longer, wait for the fluid to come to that most posterior hole. And the more posterior the hole, the easier that it'll be to remove, not wanting it to go to the macula and have all those folds and problems and issues. So if you're going to do, when I prefer to do a PFO to silicone, my preference is PFO to air silicone. That way I know that I've removed everything, all the traction, and the retina should remain attached. If it's a very large giant tear, which sounds like, you know, a super big, huge thing, but you know what I'm trying to say, there's giant tears that are 91 degrees and there's giant tears that are 360 degrees. So these very large giant tears, which are the ones that most likely will have slippage, in these patients I leave PFO in place because even a little bit of subretinal fluid forms a little bit of it just allows the retina to slip. And you think you've removed it all, and there's always some. So in those cases, those are the ones that I do leave PFO, leave it in the eye, laser what you need to laser, and then come back later, 10 days later, remove it. And usually they don't need to go to silicone oil if you've done a good job and there's no traction. Whenever, the few times, and I have to make a point, son muy pocas veces que hago este intercambio de perfluoroxano directo a silicón. So the few times that I do it, and sorry for the Spanish, guys, is when I have a situation that I'm truly worried that if I go to PF4 air exchange, that I'm going to have a problem with what's happening in the retina. I may feel that I haven't been able to do a good peripheral vitrectomy because of visualization, problems with the choroid, trauma, whichever it may be, which, you know, you obviously don't want to do that, but sometimes you know that you're stuck between a rock and a hard place. So in those situations, what you want to do is inject the silicone oil, and with simultaneous visualization, you put a cannula, a soft tip, for example, open to atmosphere, so not connected to extrusion. So for this technique to work well, you probably need to use a chandelier because you're going to need an extra hand, okay? So you use a chandelier to see, so you're not using the light pipe, and you use your left hand, for example, with an open to atmosphere cannula on the optic nerve head, which is the most posterior point, and then the other one you inject the silicone oil. The silicone comes from the top, and it literally pushes down the PFO through the cannula at the most posterior point. The problem is that you think that you remove all the PFO, and you truly don't. You remove 99% of the PFO, but there's still going to be some that you're going to miss, in my experience. And if somebody has a better technique, I would like to know it. But I'm gonna do this back to my people here, lecturers. On the lecture of silicone oil complications, I noticed that the speaker from Germany, forget his name, and I don't want to mess up his name.
Dr. Johan.
Yeah, mentioned progressive thinning of the retina in these cases. There's another thing that I see relatively often, which is cystoid macular edema. And I'm curious about your experience with silicone oil induced cystoid macular edema, in which you take the oil out, the edema goes away, vision as well. If something happens, you have to put the silicone oil back in again, like immediately within weeks, you have CME. And I'm curious your opinions and management.
Dr. Regillo?
Yeah, actually, you made some great points, by the way, and I echo a lot of what you said, especially about removal of the perfluoro. making sure you get that sandwich of fluid of BSS between the air and the perfluoro. That has to come out first. You go right to the break, like you said, and then do it slowly thereafter. Right? Best way to get all the fluid and then the perfluoro out. All very good points. I agree. With regards to silicone oil, I think some of the macular changes appear to me to be unpredictable and idiosyncratic. I'll see some diffuse cystic changes under oil in some cases and none in others. I thought Johan's talk was very interesting, and I think everyone that has operated long enough have seen these cases of unexplained vision loss in eyes with oil. We know there's been cases, histopathologic cases of oil that have been found in the optic nerve. I do believe optic neuropathy does occur in some of these eyes. So there could be direct retinal and or optic nerve issues that lead to unexplained or decreased vision or poorer vision than you would have expected, knowing that the macula was minimally involved or not involved at all. I agree wholeheartedly. I tell patients, I'm going to attempt, I always strive to take the oil out, and I try to get it out right around the 3-month point. I try not to leave oil in much longer. I really think the risk of having a problem with vision loss, whether it be retina or optic nerve, goes up over time. Now, of course, we all have these terrible trauma cases or cases that can redetach when you try to remove oil and you need to keep it in. Some of them do well, some of them don't, but ideally it's best to take the oil out. With regards to the cystoid edema, honestly, I don't really know what that mechanism is. I've seen it. Sometimes it happens, sometimes it doesn't. Again, I usually strive to take the oil out as soon as I can, and then I can address that. Usually it's with intravitreal corticosteroid injections post-operatively, and I do see patients will respond to that and have vision improvements.
It's something, obviously we don't have it that often, because I agree, we want to remove the oil. It's in those very few patients that you, for one reason or the other, have to put the oil back in, right. And you know that you're losing vision for the cystoid edema. Right. And treatment-wise, I've tried to inject, and this is specifically the patients that for one reason or the other, you require chronic oil.
Oh, okay.
And I've injected, so because obviously you want to just remove the oil. So the ones that you can't, I've tried to inject Avastin into the oil bubbles. I've done some Thielen Scanalog with partial responses, and I'm just curious if anybody has a solution to that.
No.
Un minuto.
Yeah, so I would just like to thank all the speakers and my co-moderator. And before she says her last word, I would like to just mention that as Mario and all of you mentioned, the outcomes are really fantastic right now, and the expectations of many patients, particularly those who have undergone some form of refractive surgery, are tremendous. But we still have to remain grounded in terms of the potential complications. And we spoke about tamponade today, and this is understanding that the rest of the surgery went just fine. The vitrectomy, the buckling, or whatever we had to do to attach the retina went just fine. And we spoke an hour about what we're going to use to keep that retina attached and not being toxic to the retina, allowing it for the best visual outcome, etc. So I think we have a long way to go, but where we are right now is a very good state as well. And I would actually like to thank you again. These were wonderful talks. The future is very promising, and I would like to ask Adriana to give her final remarks.
Well, as you said, thank you so much. This is a very promising future for all of us. And we will still using PVO and silicone oil for all of our cases. We're still learning a lot of it. And once again, thank you, all of you, for your time and for your wonderful work.
Muchas gracias a todos.
Gracias.
Thank you.
Good evening. Adiós.
Muchas gracias. Hasta luego.
Hasta luego.